Welcome back from lunch and posters. We're going to kick off the second half of our day with a plenary talk on 4T. Some of you have already been a part of the 4T pilot project from Stanford. So we've had 15 clinics in pediatrics express an interest in this, but you're going to hear about 4T as a concept of expansion to adult care. So Dr. Prahalad from Stanford will moderate this group and introduce her panel. Thank you.
Good afternoon, everyone. Welcome to this panel. I'm really excited to have this panel talk about how we can translate 4T into the adult world. And before we get started, I wanted our members of our panel to just briefly introduce themselves so you know who they are and what their expertise is.
Good afternoon. My name is Jeannine Leverenz. I'm a nurse diabetes educator at Stanford Children's.
Hi, I'm Franziska Bishop, a staff scientist at Stanford and work with Jeannine and Priya on 4T.
Hi, everybody. Mathioudakis. I'm an adult endocrinologist at Johns Hopkins.
Hi, I'm Kathryn Fantasia. I'm an adult endocrinologist at Boston Medical Center.
Hi, I'm Sushma Reddy, adult endocrinologist, currently doing consulting work with Tidepool, as well as principal investigator for a diabetes care management program study using CGM and RPM.
I'm Brandon Arbiter, CEO and co-founder of Tidepool, and I live with type 1.
Wonderful. So I know many of you already know what the 4T program is, but for those of you who are not here, I'm going to ask Jeannine to really briefly talk about the 4T program. We've got some slides. Let me pull this up. So Jeannine, please talk about the 4T program.
Okay, so briefly, we did have a standard of care that had limited technology use within the first year, had a cadence of 7 fixed visits, and we missed a lot of opportunities for dose changes. So we came up with a program where we initiated CGM within the first 30 days. We encouraged pump or AID class within the first 3 months, exercise class, remote patient monitoring billing, and patient-reported outcomes. So our workflow is that someone is diagnosed with diabetes, that we get a CGM on them, we get them connected up, we get them into our system and begin doing remote patient monitoring first once a week for the first 3 months and once a month thereafter. And oh yes, and sorry, and when I said get people connected up, we have a smart device for them if they don't have their own, and then we do our remote patient monitoring using Tide in Tidepool, and we'll explain more about that, I think. But anyway, we rank our kids so that we know who's at higher risk for hypoglycemia or not meeting targets. So that's how we know how to send or who to send messages to. And then we bill for our time once a month. We have shown good results. We have dropped, overall, the hemoglobin A1C has dropped by 1.1%, which is clinically significant. And we've increased from 28% to 64% of our patient population meeting the A1C target of less than 7% at 12 months. And we've shown that this improvement is sustained through 36 months post-diagnosis.
Thank you, Jeannine, for briefly explaining the 4T program for new onsets. My first question actually is for you, since you were one of our early adopters of this program. As a diabetes educator, what do you think has been essential for making this program as successful as it has been?
So I think several things come to mind. One is you need a champion. You need someone who is willing to take it on and infect the rest of the CDE team to want to do this project. I think you need some sort of dashboard. We worked a lot with our engineering students at Stanford who created our original dashboard. We worked tirelessly with them, saying this is what we want, no, this is not what we want, yes, this is what we want, kind of messages. And now we've been working with Tidepool to get it integrated into Tidepool. So you need some sort of dashboard to help you. You need CDCES and division buy-in, so you need to be educating like we were educating our colleagues constantly. Dr. Prahalad and I were working together constantly, trying to let everybody know about this project, along with Dr. Maz, and what it meant and what we were trying to do until we could get everybody's buy-in. And it was not always easy. And then you need a funding source for devices. We were fortunate to get, Dr. Prahalad got a grant through our auxiliary to fund smart devices so that we could offer it to everybody. We weren't just offering it to those who had the ability, but we were offering it to all of our patient population. We have about 40% of our patient population on public insurance, and many of those do not have the ability to have a phone. So we started off with iPod Touches. Then those went away, and now we're on iPhone XCs, and we provide those to families who don't have access to a smart device, because you do need to find some sort of funding to be able to provide a smart device for families.
Thank you, Jeannine. And a big part of moving this program from research to standard of care like we've done now is to make sure that this program is sustainable. And so my question is for Franziska. I know you've worked tirelessly on this, but can you discuss how we are billing for our remote patient monitoring? And what do you think this can add to the division economically to make this sustainable?
Yeah, so it's a long process. So, but I think first you just really need to understand the workflows and the operations. So working really closely with the CDCESs of understanding and really co-designing with them from the very beginning. So understanding the workflows, so then billing matches operations. And then educating yourself. I'm not a coding expert, so I really had to dig in to feel like, okay, when I go to billing compliance, I want some good knowledge of what are potential codes we could bill for. Billing compliance will then tell you what they would like to proceed with, but ultimately we identified actually a CGM interpretation code, 95251, versus an actual RPM code, because it matched our billing flow the most. So it was the most specific code. And then understanding your internal financial structure. So for us, we wanted to start with a code that generated RVUs, because then the revenue would go back to the division versus just at the hospital. And so that's why we ultimately chose with 95251. We piloted it, we published on that to create a framework, and now we're looking to expand into actual RPM codes like 99457, 99454. But keeping up with those partnerships, creating the partnerships with billing compliance, IS, takes time, and it was amazing, and Priya was on those meetings with me of, it's like, oh no, we need to loop in this group, or this group, and this group. So it just took time to create those partnerships, but once you create them and even pilot a billing workflow, making sure you keep up those working groups. So for instance, we just went through a voluntary internal audit of 95251, and we identified some issues. So one, I wanted to see what revenue we're generating. And thankfully we're generating some, but there was just little things like such as how the billing profile in Epic was set up between RD CDCESs and RN CDCESs was different, and that was impacting the revenue we're generating. And so, checking in with those partnerships that you've created at your institution and keeping that going. And it was interesting because the reason I reached back out to billing compliance was to expand. I was like, let's add 99457 and 99458 so we can expand our revenue. And then we're like, oh, but we should audit what we're doing. And then, now it's kind of but so just keeping up with those.
Then they tried to fix it.
And then they changed her, Yes, and then, Yeah, and I think the biggest thing is, it's just continuing to work with the clinical care team, keeping up with those collaborations, keep, looping in the hospital leadership to kind of report back on that revenue. So and then also I think publishing is really important. So we published on that pilot billing, and then we also submitted something to ATTD to see what the revenue we're generating and really disseminating those results for others to hopefully incorporate and expand.
Franziska, my next question is going to go to the Tidepool team, so Brandon and Sushma. You guys have been very helpful in bringing this dashboard our Tide dashboard into Tidepool, so that's available to more people. Can you tell people here if they're interested in using the Tide dashboard as an RPM piece of software, how much of a lift is it actually for their divisions or their institutions to start using this?
Thanks for that question. So there's always a contracting piece anytime a health system is going to start working with a new vendor, right? So that's pretty standard depending on how quickly your clinic or your health system can operate. It could be anywhere from 6 weeks wall time to 18 months wall time. Hopefully for all of you, you can, it moves faster. But from our end, we try to do a 24-hour turnaround anytime we get an agreement to review or something like that. The IT team at the health system will also generally want a vendor like us to fill out a security survey. We've actually now automated that process, so we can turn that around quite quickly as well. Once that's out of the way, you've got the security survey and the legal stuff done, then you move into the implementation. If you want to set up single sign-on, which means you're using the same username and password you use within your health system to access Tidepool, to access Tide, that is about a total of 4 hours of work. It gets spread out about over a week of time. So from start to finish, it'll be about a week, but it's very little time, and it's just your IT security folks give us a package that they give out to, 100 vendors a week. So pretty seamless. If you are not going the route of EHR integration, then once you've done everything I just described, you are set up and you can begin using Tide in your clinic. The IT lift is basically as I described. It's quite limited. And then it's an intervention lift. And that's when I will encourage you to start talking with Dr. Sushma Reddy, who works with a number of our clinics that are implementing Tide. We have a clinic success team at Tidepool that will help you manage the interventions and the workflows that you want to do and how to configure it and customize it for what your needs are, whether you want to start in new onset or start in pregnancy or wherever it is that you want to use this technology and deploy it for. If you want to do an EHR integration, that's typically about 10 weeks from start to finish. So that is another thing that you can do, and it's an option, but it's not required.
Thanks, Brandon. So I'm just going to bring this back to our original topic: is how do we move this model into adult care? So I'm going to address this question to our 3 adult colleagues here. In the 4T program that we're doing at Stanford, we're starting with people who have newly diagnosed diabetes. But I know in the adult world, you see fewer people with newly diagnosed type 1, or you might get them a little bit later after diagnosis. So how do you see a remote patient monitoring type program working within your practices?
So we're actually doing a study with this, and we're actually seeing amazing results. I'm just very geeked about it. But the way we've done this is we took all patients with type 2 with an A1C of over 8, so uncontrolled, and they were all offered a CGM as soon as they came in. Half of them were on insulin, half were not. And then they were all connected to Tidepool, so we can now see their data on this nice Tide dashboard. So now we can look at those people that need outreach. So the way this works in clinical practices, it has to be part of your workflow. So our workflow is the medical assistant, when she walks in Monday morning, she looks at the Tide dashboard. She first goes to an area that talks about data connection issues. There's very few that have any issues once they're connected. So if there are, she reaches out, takes care of them. She looks at those who are meeting targets where you can mark reviewed. She then looks at those that are high or low, having high glucose or low glucose, and then looks to see if they have an appointment that week. If they do, we need to do nothing, they're coming in. If they don't, she sends a message, in this case to the diabetes educator, or it could be PCP because I'm doing the study in a primary care clinic right now. There's no endos there. And then there's outreach made. But when that diabetes educator or PCP looks at the Tide dashboard, they can also see if this patient has improved over the last 2 weeks. So let's say somebody had 30% time in range and now it's come to 50. They're still not at goal, but they're improving. They don't need an outreach. So ultimately it ends up that the outreach occurs to about 10 to 15% of patients in the adult type 2 world. And half of these, about a little over half were on insulin and half were not. So this is how it's working. We're seeing such amazing results that they want to apply it to the rest. We had people with A1Cs over 10, 14, getting to a GMI in the 7s within 2 weeks and 4 weeks. So I hope to share some of this at ADA this year.
Sure. So as I mentioned, I practice at Boston Medical Center, which is a safety net institution. So 70% of our patients are publicly insured. About 30% speak a language other than English. They have a non-English language preference. And so I think that there are perhaps some commonalities with what Jeannine mentioned. You know, some of our patients don't have compatible devices, and thinking through that piece. I think thinking about the characteristics of our patients, characteristics of the intervention, you know, what is the effectiveness in, you know, folks with type 1 diabetes who've had diabetes for longer than those who are new onset? As Priya mentioned, we're not seeing a ton of folks with new onset type 1 diabetes in our clinic. I think, you know, most of those people are being seen in primary care or unfortunately are experiencing misdiagnoses. But thinking about, are there patients who are particularly high risk? So does that mean people who've had inpatient admissions, either for DKA or severe hypoglycemia? Are there folks who are experiencing a high burden of hypoglycemia or hyperglycemia that we can target? And I think one of the other sort of special considerations in an adult safety net clinic such as mine is resources and staffing. So you talked about a champion and how critical it is to have a champion, and I totally agree. And I also think that people need to have their work compensated and protected. And so thinking about what are the structures that can be put in place to facilitate someone managing the remote patient monitoring. And I'll pass it over to Ness.
Yeah, I agree with many of the comments that were made earlier. I do want to dive a little deeper into this compensation and protected time piece, because I think this is critical in the adult world. So I was the clinical director of our division for 5 years, and you know, the value proposition of this is super clear to clinicians, right? There's evidence that this works, but to operations leads and administrators, you need a business model, and you're going to need to show sustainability in terms of charges and salary. And so one of the, I think, important problems that we face in adult diabetes is we have people available in clinic. They're available to our patients, but the no-show rate is really high for the most vulnerable patients who could benefit from this service, right? So you have diabetes educators in clinic. Maybe they have, I don't know, 16 patients on the schedule, but they end up seeing 10. So if you were to implement a remote patient monitoring program, is this incremental work that a diabetes educator is doing? In other words, they have their scheduled slots, and then they have like a morning where they're doing the RPM work on top of that? Or are we backfilling missed appointments to maximize, you know, people's productivity? And that's one important point that would need to be sorted out. And then the second is that diabetes educators can't bill for this work, right? The CGM interpretation code. So in essence, this is going to be more work coming to the endocrinologist in their in-basket on top of my chart messages. And is that time protected, or is that just time that you do outside of your clinic schedule? Right now, I think it's the Wild West in my chart, right? I mean, we're getting these messages really disjointed and fragmented. So if there was actually a structured RPM program, many of these messages might stop coming in. So we actually might see a net reduction in the in-basket burden. But I think understanding the allocation of FTEs, both of the diabetes educators in clinic and availability to do the RPM work, and then how do you protect the time of the endocrinologist to actually review and drop the charge is going to be a critical point.
I want to address some of those a little bit. So we each have about a half a day we try to block off. Sometimes, some weeks that doesn't work out because we get an onslaught of 6 or 7 or 8 new onsets in a week, and then it's, well, this week's just not going to happen. But most of us can block off about 4 hours during our week. But then we also fill in when when it's a quiet clinic but I'm between patients, I can pull up my list. And because of Tidepool did a request that we had was when we did the review for the week, we wanted a check mark. So when I pull up Tidepool and I started Monday on my list and now it's Thursday, I know where I'm at. I know, okay, I've already done all these. I don't have to go back and go, did I do that one already or not? So that really helped us a lot with, just being able to do 1 or 2 between patients in clinic. And then we drop the charge and do all the charting, and then I send it to Dr. Prahalad, and she co-signs it. So she gets the RVUs for it, and we get them. We drop the charge, and she just reviews what recommendations I made. So I don't think it's horribly cumbersome, but she would have to answer that part.
I would say it's probably the co-signing is not super cumbersome. I've created dot phrases for those of you who use Epic to just say, I see it. Our compliance department does require us to copy and paste the dose adjustments. So I copy and paste it from the diabetes educator note into my section. But I'd say it takes about a minute or 2 per note. But it's still something I do in between patients or, when a meeting runs short.
Yeah, so I'm going to push a little harder here on this point. The reality is that the diabetes educators and the nurses or whoever's doing the interpretation and calling the patient and making the decision is doing the hard work, right? And then it's routed to us. We click a button. We get the RVUs. We get the productivity bonus, right, that is associated with those extra RVUs. I think in order to have diabetes educators incentivized to fill all their unused time in clinic doing this extra work, they need to get the compensation back. So if I could do like 15 of these and I'll get all the payment, we get a fraction, they get the majority of the charges.
That would be great. In our institution, our pediatric diabetes educators are not required to meet RVUs. So I'm not as concerned about that. I get paid no matter what my RVUs are, so I'm happy to give it to Dr. Prahalad and to the division. So that's just because of how our CDE team is structured. And I think that's the case in many pediatric settings, but it's not the case in my adult colleagues. So I know they are trying to fill the RVUs, and so that would be something more to consider.
And just adding to that, there's an RPM code called 99454, which is just looking at the data that's coming in, the glucose data, which is 16 days of data. And there's a new code now, which will start in 2026, 99446, that looks at 2 to 15 days of data. That does not have any RVUs associated with it. So if you're an institution and are billing for that, please make sure it comes back to your department to fund people like Jeannine who do awesome work and make our lives so much easier and those of our patients.
Yeah. And I just want to, ask this question since we are on the topic of, paying for RVU, paying for people's times. I think one of the things that we've been able to do in our pediatric center is to use our outcomes data and some of our billing data to advocate for additional diabetes educators. I know it's a little bit different in the adult world, but how do you think RPM could maybe help support increased resources in your groups?
It's a really good question. We actually scaled our DSMT program across our health system, and every additional hire was scrutinized at the very highest level. So scheduling, utilization, productivity, RVUs, revenue had to be one-to-one in terms of hires. So if we could demonstrate that, if somebody's 80% show rate and their 20% is backfilled with RPM, and it covers them and more, of course, it's a compelling argument to retain the staff that we have, if not to augment. But I think in today's financial climate in an academic medical center, it would be really difficult to bring on an additional person doing RPM until you can demonstrate that your existing staff, with the effort allocated to do this work, cover themselves with that proportion of their time.
Yeah, definitely. So thank you for this discussion on the finances of doing RPM. I do want to change the topic a little bit to implementation. So, Kathryn, how would you use an implementation science approach to bring an RPM or 4T type program into your safety net hospital?
Yeah, thank you so much for this question. And just to preface my answer, implementation science seeks to create generalizable and transferable information around what strategies help clinicians to do evidence-based and evidence-informed things like the 4T program. And so, within implementation science, context is critical. What we're hoping to do within implementation science is understand what strategies will work across contexts or within similar contexts. So within a safety net setting, what are the things that can help us do a remote patient monitoring program like 4T? I think that understanding context is the first step. So even though many of us are clinicians within our health systems, we're embedded, we know our colleagues well, I think taking a critical look at what are the needs and the resources of our patients, of the clinicians, and the staff that we work with, what are the priorities of leadership, both within our clinic structures and at an organizational level, and what are the characteristics of the intervention, right? Jeannine, you mentioned that recommendations are sent via portal message. That's interesting. That's something I want to come back to, and something that I am considering in my safety net setting where, about a third of my patients have a non-English language preference. But understanding the determinants of a practice, so the barriers and facilitators to a practice, can help us to then use either behavioral theories or empiric evidence to select strategies that may be effective. So champions are a great example of that. Having someone who's really invested, maybe initially covering their time through some other mechanism and then making a financial case as necessary. And then I think the other thing that's critically important is looking at early process outcomes and implementation measures that can help us understand if we're succeeding or failing early, right? Like, we don't want to spend 6 months implementing the 4T program only to realize that all of these patients that we enrolled in remote patient monitoring weren't receiving any of the MyChart messages and therefore aren't making any changes in their diabetes management. So an example of that within my sort of like safety net context is, we have very limited financial and staffing resources. But we have a clinic leadership and a diabetes clinical leadership that has been historically incredibly supportive of interventions that we've done through the exchange to increase technology adoption. We also have some really helpful resources within our organization. So we have a pharmacy liaison team that helps us with prior authorization. So we have a really high rate of CGM prescription and uptake in our adults with type 1 diabetes, like upwards of 80%, facilitated by a technology navigator in our pharmacy liaison. And looking sort of more broadly at the organization, we have other sections and departments who are already doing remote patient monitoring, but in other disease states. So within our obstetrics group, they're doing remote patient monitoring for hypertensive disorders of pregnancy using a remedy-based platform. And so what can we learn from them? How have they navigated the billing code process? Are there organizational resources that we can share to build momentum to develop remote patient monitoring programs across the institution and for a variety of chronic conditions? And then the last thing I would say that would be critically important in doing this is understanding our patients' needs and resources. So many of our patients do have smartphones, but most of them are using readers with their CGMs. And so, the education that it would take to transitioning to using a phone as a receiver. Some don't have phones that are compatible, but many do. And then designing with equity at the outset, which I think is critically important. So it may be that a MyChart strategy for sharing recommendations with patients is not going to be super effective. And so I would love to hear from you all if there are other strategies like phone-based strategies that would work, because I think that would be really important to my colleagues in knowing that, you know, any work that's invested, that the recommendations are reaching a patient. And I think is critically important for that idea of incremental work, right? Like it's very different, I think, to send off a quick MyChart message than to call a patient with an interpreter and try and get someone on the phone.
You bring up some really good points, and we have dealt with a lot of those. So we have a lot of our a lot of our families also don't speak, English is not their first language. And so we will interpret them or translate the MyChart messages and send them out. But if we don't think, if it doesn't say they're read and we don't see that they're being read, we will make phone calls again, you know, either in our protected time or, you know, if we have a low clinic. One of our CDEs is bilingual, and so he has taken on more of those, and by far he makes more phone calls. We've also tried to get some sort of texting available. Our social workers can text the families, and so on some of our more high-risk families that I'm more worried about, I'll go to the social worker in that clinic and say, hey, would you send a text message that says X? And when they reply to them, tell them this, you know, or if they reply, come back to me. And so I've worked really closely with our social workers to help get those messages, because we haven't gotten permission to text. We're trying, but we'll see where that goes. But so we have tried those. And then just to circle back too about time, before we started doing remote patient monitoring, a lot of our CDE time was spent doing SMNs and prior auths and getting approvals for medications and devices, and we spent a ton of time doing that. And Dr. Maz fought really hard and got us a pharmacy tech who did all that. So that took all that off our plate. So then we had more time to really work at the top of our certification, which has been more rewarding for all of us than doing what we felt like was just paperwork stuff. It was cumbersome, needed paperwork, but it was just hard on all of us. So doing the RPM has really felt like we're working more at the top of our certification.
Thank you, everyone. I just wanted to open this up to the audience for questions. I know the Stanford team has some experience in RPM, Dr. Reddy has some experience, and I know Dr. Fantasia and Dr. Mathioudakis also have thoughts on this. So I'd love to hear if anyone has questions they'd like to ask about how they can bring RPM to their practices. I think I see one back there, two back there.
Not so much bringing to the practice as much as billing questions. When we started billing the code 99251, our billing office initially told us we could do that only every 4 months. So I'm curious if you know how often you can bill, and then also, are your patients getting any copay for what you guys are doing? Because that was a problem we were having before.
Yes, great question. So for us, for our billing pilot, so the code is every 30 days. So I'm not sure where format, it's every 30 days. However, we also, that same code is dropped by the endocrinologists at those standard of care in-person visits. So we do prioritize those. So basically when Jeannine goes in and looks and drops a bill, she'll see if they've been seen, say that same month, and then she won't bill for that RPM. So there's a little logistics. We wanted to build in a very simple framework, simple, funny, within Epic to catch those, which wasn't possible, so that's a manual process now. But no, 95251 is every 30 days. Like I say, we did have to co-sign and do a co-attestation for that for Dr. Prahalad. And then, yeah, it took us a long time to get through billing compliance. Kind of the novel thing that we started with the 95251 is having the CDCES as a service provider. And that's what took, 9 months to to say, like, no, this is the case. And then that was also wrapped into, it's also the case that CDCESs can adjust insulin. And so Jeannine just had a paper published last week that Yes. That publish that dosing policy, because that kind of goes hand in hand when you're working with billing compliance.
I have a quick question.
Sorry, 2 seconds, just about copays. They range, typically what we saw is we worked with our family advisory panel and they said, around $35. The average copay was 25 to 0 for us, public and private, depended. Sometimes it did go to the deductible, but typically deductibles are met within the first year. Now we have patients over a year after new onset, and so we have had some patients like, oh, I got a bill, I wasn't getting a bill last year, because they haven't met their deductible. So fortunately, that hasn't happened only a handful of times, because even the deductibles, I think on average, $110, which is, that's a lot. It's not gonna be per month forever, depending how big your deductible is. But we're also fortunately able to identify some philanthropic funds, so we have it set up where if a patient has a copay related to RPM billing that is burdensome, they can apply to financial counseling. If they get if accepted, then all of their diabetes is supported. But if they don't get accepted, then our philanthropic support kicks in to support that patient. Because the last thing we wanted to do is start billing and then inadvertently, have it too burdensome for some families, and then those families don't receive RPM. So.
And then just talking about experience billing across the country. Can you hear me? For the 95251, as Franziska reported, just talking about the billing experience across the country, some things can vary. The 95251 is typically monthly. There are some commercials that will only allow it every 3 months. And when you're billing it at the time of the office visit, make sure there's like a modifier, because some insurances will kind of build it into that office visit and not pay for it. So make sure that that is there. And then for your RPM codes, which are the 99454s and 457s, one of them is every 30 days, the other is monthly that can be billed, and it's covered by most insurances. United Healthcare just said that they're not going to be covering RPM for diabetes, and then some of the Medicaids in some states do not cover it either. And then if you bill the RPM codes at the same time, usually the patient just gets one copay, so it doesn't feel like they're stuck with, oh my God, this whole big copay all at once. So.
Hi, this is Carla from Reddy Children's Hospital San Diego. Thank you so much, great panel. I understand, could you comment something that I understand that the patients need to consent, they need to know ahead of time that this is going to start. Do you have a document that you add to the initial consent when they come to clinic? How was this done?
I'll have, but just to start with, for Stanford experience, with 95251, since it's in CGM interpretation, that does not apply. That's an issue with 99454.
Yeah, as mentioned, you do need a consent, so the consent could be verbal or written. So there are a couple different ways. I think the best way to do it is as an institution to say this is the quality of care we provide, and have that into your general consent. That here, if necessary, you will have remote patient monitoring done and describing it. So that would be part of just your general consent. And then obviously when you start the service, you're going to tell the patient, we're going to be remotely monitoring you and here's what we're doing. And then you would just put a note in your chart that you explain to the patient about remote patient monitoring. And so then if you don't have it as part of your general consent, then you have a separate consent at that point. That we usually have them sign. Verbal is accepted, but it would be better to have them sign so they understand that there may be a copay associated with it. It's not a 24/7 service. We're looking at this maybe on a weekly basis during your clinic. If you have high or low sugar, please treat according to whatever guidelines, or go to the emergency room when needed. So that way it's all really spelled out very well for the patient. And I'm happy to share that template language as well.
Risa Wolf from Hopkins. Do you have a protocol, and maybe this is a question for Jeannine, like that goes over like what kind of dose changes the nurses can make and within what range?
Yeah, that's what the paper is that I just published last week. So I'm doing a talk after this, and I'll have the QR code available, but I think Nicole has it, so maybe she could send it out so everybody has that QR code, because I know that that's been a question that's come up a lot since we started this project. And so I was really excited to say that it was safe and effective to have CDCESs make dose changes. And we make them within 10 to 20%, 1 or 2 changes at a time. So we spelled it all out in our protocol. We came together as a group and decided what our priorities were and what kind of changes we would make. The only time we make something more than a 10 to 20% is if we're dropping the doses because they're going into honeymoon and we need to drop the doses rapidly.
Thank you, everyone. We're at time, but I wanted to thank all of the panelists for sharing their knowledge and their experience. And if any of you have lingering questions, we're all around, so please feel free to stop by and ask us questions.
We also have a computer set up outside. Local celebrity Christopher Snyder. Wave. So if anyone wants to explore the Tide dashboard and what it looks and feels like, he's got a computer set up. You can go ahead and do that.
Thank you, everyone.